It's because you have the possibility to do pedicle soft tissue grafting techniques on the palatal side, on the buccal side, to do the classical approach, or sometimes the Bruno approach. Every case is different. I have no time to explain every situation, but I think we need different approaches and to choose the right approach for the right patient. What is important is to know how much tissue do we have in the palate. I have around, oh my God, I have around 2-4 millimeters of soft tissue thickness. So most of the time, I have enough tissue to take a connective tissue graft. Of course, I have more tissue in the tuberosity. So do I need to have to graft and only in every case? I don't think so. I only use this technique when I have less than 2 millimeters. Look at the picture, less than 2 millimeters of thickness in the palate. It's very easy to harvest the graft in that way, but I think it's not always necessary. You see the video, cut it off. I leave the periosteum in place, and in that way, it doesn't hurt at all. After that, of course, I take out the epithelium, and also if the fat, if I have fat in the graft. But it's a technique I use around 5% of the cases, not more. I think it's not necessary to use it in every case. Sometimes I had problems de-epithelializing the soft tissue, so I observed that some epithelium is into the graft and causes problems. But okay, it's another possibility. And the second indication. Sorry. The second indication is only graft for vertical regeneration. Sometimes I like to have soft tissue and also epithelium for vertical regeneration. This is after a vertical regeneration. I let it heal after placing the implants, and then I placed an only graft on the vertical side, okay? In order to get not only epithelium, but also thickness of tissue, in order to get more predictability for the papillae. You know that those cases are very demanding, and sometimes we don't get the results we want. These are not really papillae, but the case was very demanding. But at least it's not a bad case. It's acceptable, I think. How much length I'm able to take? Around 35 millimeters and 8 millimeters. This is another video showing you that sometimes I'm able to extend the quantity of connective tissue from the tuberosity to the frontal area. Sometimes I'm able to take around 40 millimeters of soft tissues. And then, if you use both sides of the palate, you end up with 80 millimeters of soft tissues. It's quite a quantity of soft tissues. Which one is the best area to harvest a connective tissue graft is another question. Some guys tell you the best is the tuberosity. But I think it's a good tissue, like you said, for some places, pontic sites, but I don't like much for covering recessions. So they are different. This is an only graft. This is connective tissue graft from the palate. This is from the tuberosity. This is a mixed graft, and this is an epithelium graft. Some guys say, okay, the quality of the tissues from the palate are quite bad. Sometimes it's true. Sometimes it's true. And from the tuberosity, we find better quality of soft tissues. It's true. But the problem with the tuberosity, first of all, we have many techniques to take out soft tissues from the tuberosity. The problem with the tuberosity, as you all know, is that some tuberosities are quite small. Of course, for one single implant is more than enough. But we are not so lucky that we have these kind of tuberosities in every patient. Of course, if you have that tuberosity, you are gonna get around 50 millimeters of soft tissues. But this is quite exceptional. And this is a very thin soft tissue graft, very thin. You see that summarizing what I always do, of course, is to take out the epithelium. And not only that, you said that before, is Vanna, the name is for me, it's quite difficult, you know? Yeah, it's not, yeah. You said that before, we shouldn't place those thick grafts without directly in the side. Yeah? It's better to thin the graft before placing it. I agree with you, absolutely agree with you. But we get a huge quantity of soft tissues from that tuberosity. Sometimes, only sometimes. Take out the epithelium and make the graft thinner. That is my advice. How thin? Around 1 millimeter, not anymore. Look at this. Look at this picture. It's almost transparent, okay? 1 millimeter is more than enough. Then you can graft not only on the back side of the implant, also on the back side of the canine. And you see that the quality is very good. It's very thick. But we are not going to have that problem you mentioned before, because it's very thin. You will observe that and no problem at all, because it's very, very thin, probably less than 1 millimeter. So in my experience, this is a little detail to take into account, okay? How do I suture the connective tissue graft? I could spend a whole week talking about this, but I want to focus my lecture today because I don't have much time. I mean, I'm trying to speed up because I have too many slides. And you saw this article. Probably all of you know this article from 2009. And some of the pictures I see every day are using these sutures. The problem is, well, actually there is not any problem, but I analyzed my clinical cases done before 2009. Look at this clinical case. And we didn't use that suture at all because we didn't know it. So let's look at the result. Years later, I have a very stable and nice result, 12 years later. Very stable result. But you say to me, okay, Ramon, but this is a shallow recession. This is a very simple recession. I understand you don't need to reposition the flap with a suture. This is very shallow recession. I was thinking about the idea that if I use a lot of sutures, it takes more time to me. And it's more time for the patient also. And is a more expensive treatment. So I use those sutures, absolutely, but not always. This is the result. And this was published in 2009. I used those sutures in Miller class 3 and papillary regeneration in less predictable cases, but not always. You may use them when the connective tissue graft is very thin, or you are approaching a large recession. Very useful in order to cover most of the connective tissue graft. You know what? Those cases were done before. Let's look at those cases, before and after. I did not use that suture. I used a sling suture because this case was done before. The article was published. Let's look at this case. I didn't cover the connective tissue graft because I didn't know about the article. I didn't know anything about dentistry, you know, at that time. But okay, I don't know much now, but so you say to me, oh, Ramon, but look at the result, not very good. But the good thing about getting older, you have to wait, to learn how to wait, you know. So let's look at the case after some years. We didn't know anything about this. 6 years later. 6 years later is not much time. Let's look at the patient in 2008, 2013. Okay, let's look at the patient 15 years later. 15 years later. In 2018, this year, 6 months ago, more or less. Quite a result. It wasn't covered at all. So the question is, you said that. The question is really necessary that suture? Maybe, I don't know. 1998, I've been working since 1996. 2002, you understand why did I do the soft tissue grafting technique? Because the trauma the patient was applying to the gingiva. 2003, 2018. Hey, guy, the tooth is almost square. You see? The creeping attachment. And it's a connective tissue graft, not a free gingival graft. Look at the biotype in 2018. Thickness of the gingiva. It wasn't covered at all. This is more or less summarizing the case. So sometimes I don't know. I have no the answer for many questions. Sadly. So do I have to completely cover the connective tissue graft? Look at this article published by Han in 2008. If I full cover the connective tissue graft, I get greater root coverage, but only 5%, not statistically significant. If I don't have keratinized gingiva, let it exposed. It's better. I don't say that. Literature says that. It's better. And now I can understand my results. It's my experience, but now I can understand my results. So I can understand why do I have these results. The question is now is, do I need a lot of sutures around the connective tissue graft to get these results? I don't think so if the recession is shallow. But most of your recessions are shallow. Do you know that? Yes or no? Most of the recessions are not very aggressive. With implants, we have to analyze the situation, the initial situation. I can have a regular situation, a recession, or a overcorrection. If I have this situation, I don't need any connective tissue graft because I already have a connective tissue graft. I already have tissues, more tissues than I need. I don't need any connective tissue graft. But in this case, I prefer to expose the connective tissue graft in order to cover the recession or to cover fully the connective tissue graft in that other case. Of course, it depends on the clinical situation because sometimes I can coronally advance this tissue without any vertical releasing incision. Of course, there are many ways to go to wrong. And it works with a full arch also. I can plan digitally. I'm doing this stuff lately. And CAD-CAM temporary restoration. The philosophy is absolutely the same for one implant or several implants, several grafts from the tuberosity and, of course, the palate. And you see the missing lateral incisor here. And after 2 hours of surgery, you get this result. So, but the stability of the results depends on the graft you placed under the flap. In the long term, of course, not in the short term, okay? This is before, and this is the transition area after. So I can use biomaterials. Another question as an option. Yes, of course, but what I observed is the same as literature tells us. The gain in the width of keratinized tissue and amount of root coverage is not as predictable, not as predictable. I have many patients. Obviously, I don't have time to share with you all of these patients. I want to show you only Anna. I did different approaches, allograft mixed with coronally advanced flaps, and tunneling techniques with allografts versus connective tissue grafts. Also, pinhole technique with allografts here in this part of the mouth. And let's look at what happened. This is the situation before. Look, don't be fooled by this long papillae. I don't have enough bone interproximally. You know that. So in this, in the right side, I used the calf with the allograft. In this side, I used a classical approach with allograft. In the other side, tunneling calf plus allograft. In this other side, pinhole technique. You know the technique. Suture everything. Everything seems okay in the beginning. And only in this side, I use Bruno's technique very quickly. I did it very, very quickly, very simple. Let's look at the results. Let's look at the results. Let's compare the results. The best situation, the connective tissue graft, by far. I have have many cases like this, many cases. And it works better, the tunneling technique works better in my hands also than calf, maybe in my hands. 3 months later, look at the tissues. Look at the tissues before and after. I don't know, maybe I don't know how to perform calf, I don't know how to release flaps, but I get 10 millimeter of vertical GBR procedures with the match problem. So I don't know why. It doesn't work in my hands. Let's compare flap versus no flap. Better results with no flaps, and better with connective tissue graft versus allografts. The problem is, after a couple of months, the patient came back with problems of sensitivity here. So I had to repeat the procedure. And this is bad for me and bad for the patient because I didn't charge anything, you know. It's bad for everyone. So this is the result. Let's compare. Of course, shot technique didn't work in my hands. It worked in the beginning, but not after several months, not after months and months, not in the long term. But look at the connective tissue graft, and let's compare with the other side where we did the cuff plus the tunneling. And you see that the papillae, the zenith is better on the left. So in my hands, connective tissue graft wins, like exactly like literature tells us, exactly the same. So before and after, and once again, you observe that there is a huge difference where we place connective tissue graft, both sides where we place connective tissue graft. It's not only about covering the recession, in my opinion, it's about improving the biotype, Huh? So let's compare before, after cuff plus allograft, and after cuff plus connective tissue graft, 1 year later. Definitely, for me, connective tissue graft works better. And this is what literature tells us. There is a direct relation between flap thickness and recession reduction and the stability of the results. But it doesn't mean I don't use alloderm. I use alloderm because I can use alloderm in full mouth covering recession, ponticite, or membrane, or GBR procedures, having less donor side, less discomfort, many advantages. I want to share with you this clinical case, and it reminds me of yesterday evening.